Hello and welcome back to another episode of Diabetics Doing Things. We're telling the amazing stories of people with diabetes from all over the world. I'm very excited because, as you guys know on the podcast, we've been revisiting some of our favorite guests and interviews from all of the years of the podcast and our first 100 episodes. And one of my favorite, we were talking a little bit before we started recording, one of my favorite T1D athletes of all time and just an all around great dude, Dr. Jonathan David Tijerina. Welcome back to the podcast. You were on the podcast in 2017. We talked a lot about your career as a cross country and track athlete at Baylor. Ever heard of it? Going on to med school at Stanford. Ever heard of it? And now you are in your last year of residency in Miami, and you're working and seeing patients. And I'm so psyched to have you back because even though we haven't spoken that much over the years, I just feel because of our social media communities, I'm like, man, this is the guy that we need to have on to talk about retinopathy, diabetes, diabetic macular edema,
Thank
and
you so much for having me,
complications.
Ryan. I really appreciate it.
So,
Yeah,
man,
I've
welcome back
been
to the
following
show.
everything from afar.
I
I still can't dunk, so I'm jealous of that. But but I'm really excited to be here. It's been phenomenal the last couple of years here in Miami treating patients with diabetes amongst a bunch of other eye conditions. But it's been awesome. I'm happy to share.
I also want to add that when I was Googling for this episode, because I am the infamous Google stalker, that a month ago you were added as the first interior segment chief resident at Bascom Palmer Eye Institute. And it's like super impressive because they've never had that position before. They created a job so that you could stay there because they think you're so incredible. So that's also like, we have a lot of winners on the pod, but I just want to start this one with
Thank you so
reminding
much.
everyone what
I don't
kind
know
of winner we
if
have
I would phrase
here.
it in exactly those terms, but I really appreciate the way that you phrased it. Yeah, I'm super excited. It's a new position, and I'll be teaching residents next year how to do cataract surgery, we have an emergency department only for eyes, completely separate building, only for eye emergencies here, which is really cool.
We're going to talk a lot about, call it the pod, the C word, which is diabetes complications. And they are hot button issues and often, get ignored for a host of different reasons. But we want to dig in with you, the expert, and kind of explore, not just what some of these complications are, like talking about retinopathy, how common it is among patients with diabetes, but also how to build and have a relationship with your care team to, manage that. And Eritrea is also going to like share from her personal experience. But, for somebody like me who is every day is a new discovery about something with diabetes, and I'm sort of just going off vibes, which I know a lot of our listeners do.
So,
Someone get control.
little background about where I am in Miami. There's a very large population of Latino and Cuban patients, as well as a large population of Haitian Creole patients. And both of those people groups have a higher than average incidence of diabetes. So a lot of the patients that we see in our comprehensive clinics, which we run from the beginning to end of residency, same patients throughout the whole 4 years, you're adding patients as you go. So I've known a lot of these patients for a long time and seen the development of their eyes, and in some cases, the development of their C word complications over time, and tends to correlate with the control of the glucose and the control of your diabetes overall. But in some patients, we say some people are leakers and some people are bleeders. And that I'll explain that a little bit more later. But some people tend to be prone to those things happening at a lower A1C, or what you would imagine would be like a better level of control. And sometimes that has to do with other things that are going on in their body. For example, if they concurrently have sickle cell or something like that, that also tends to damage blood vessels. It's going to make you more prone to developing the same complications at a probably lower or better controlled C. It kind of varies person to person. It varies also with, we say, time under the curve. So however long you've been controlled. One thing that I try to emphasize with patients a lot at the beginning is that they come in with something that needs to be treated, that you didn't catch on a screening exam or something like that. Maybe they didn't even know they had diabetes, and this is the first time they're seeing an eye doctor, is that these problems didn't develop overnight, and they tend to not go away overnight either. And that's something that is an expectation that needs to be kind of discussed at the beginning, because otherwise your patients are going to come in and they feel like they've been misled, or they feel like, why didn't you explain to me that this was not going to be done with one treatment and we're done? And I think that's something that's important to kind of establish. But overall, it does tend to correlate with your control of your A1C, control of your glucose. And sometimes it happens a little bit quicker or a little bit more aggressive.
Can you speak a little bit to like the varying person to person we talk about, and we were talking about even
Yeah.
before we hit record, like diabetes is not a monolith, looks different for everyone. And I think we typically make that like manifested to like how you respond to food or how you respond to exercise, like what lifestyle choices you make. But you're talking like specifically about physiology and, adjacent conditions like sickle cell, like you mentioned, causing you to be more susceptible or more prone to complications than maybe someone without. And I think that's just a really important light bulb moment for me, as, kind of stepping into the role of the audience here, is that like there are things outside of your diabetes that impact what was happening with
That's
your body
perfectly fair. So,
related
yeah, I
to your
think that's something
diabetes.
that people don't tend to take into account. And even when it comes down to eyes, people have sometimes a relatively small view of what's going on. And they feel like this is my eye problem. And usually I try to emphasize also that this is not an eye problem. The eye problem is really a local manifestation of the systemic issue. And if you don't treat the systemic issue, the eye problem will always come back. No matter how many treatments I do with injections, laser, anything like that, it will always come back. And sometimes it will get worse, sometimes it'll get better. But the biggest way that we control this overall and make sure that we protect our vision in the long term is to control the sugar. That's the biggest thing. I think that sometimes people have a very narrow view of their diabetes and outside of the context of their overall health, exercise, diet, other conditions like high cholesterol and or dyslipidemias of other sorts, as well as high blood pressure are the most common combinations that we see that all tend to damage small blood vessels, and that's how they cause issues. But other things as well, in terms of keeping in mind that the eye problems are really a small manifestation of a big issue.
My question for you, like when you're talking with patients about that, like often you're delivering kind of difficult news to hear, right? When, hey, your diabetes is causing a problem in your body and with your eyes, which is something I think I think holistically all probably take our vision for granted more often than we realize. And then, as you get a little older and you need glasses or, you start to have some complications related to, other, chronic illnesses that you may have, you start to be, oh man, I really shouldn't have taken that for granted. So long way of asking, like, how does you also being a patient and you not just being a physician, but also living with diabetes and having these conversations with your own care team, like how does that help your patients, when you're telling them this difficult news and you're looking at, hey, we need to address these lifestyle factors
Oh, no,
for
I
eye health.
appreciate the opportunity to do that. I think it's something I really value, and it's not something that one person has to share with their patient. I tend to because I think that it helps establish that relationship, and the patients are often much more accepting of advice that I give them, and have a lot more confidence in the things that I'm telling them about the overall plan and the overall prognosis of their issues or lack of issues. And just kind of because they're like, he gets it. He's done it. This is going on 18 years this year with diabetes. It's been a trek, and kind of takes us back to what we were talking about earlier about screening recommendations. I think I tend to be, not to get too philosophical, but I tend to be a person who's like, if you have the option to know what's on the other side of a closed door and you can do something about it, it's better to know. And if you're a person who has diabetes and is not getting your eyes checked, the problems from diabetes in the eyes are treatable and preventable in a lot of cases with advanced notice of what's going on, because it goes through a lot of stages that we can see inside the eye before you'll notice any symptoms. And that's something that patients don't really appreciate. Oh, I have something wrong with my eyes. My vision is 20/20 and it might be perfect. The vision might be perfect and on the eye chart, but we can see that there are little spots of blood in there or little aggregates of protein in there from the damaged blood vessels that we were talking about. And even diabetic macular edema, to some extent, if it's not right in the middle of your retina, often doesn't cause symptoms. And so patients can go a long time developing these issues without knowing it. So that's why the screening guidelines are kind of in place. And the guidelines really are, if you're type 1, they recommend annual eye exams starting from your diagnosis. And then if you're a type 2 or not a type 1, or a person who's, I think a broader umbrella would be someone who's not instantaneously insulin dependent. If you're on oral medications for a while, they recommend starting annual eye exams within the first 5 years. And the guidelines for that really are based on whether or not it's probable that you could have been going years without being diagnosed. So a lot of type 2s don't know they're diabetic, and there's a pretty high incidence of people who their first presentation of knowing that they have diabetes because they're not getting routine blood work, routine blood pressure checks or anything like that, is that they have something wrong with their vision. And then they come in and they say, oh, I have diabetes. I didn't know that. And that's something to keep in mind, is that a lot of these people might not even know. And when you are the person who they come to because they've, like you said, been accepting that their vision is great, they've just been going through life, doing what they got to do, They come into the eye doctor because their vision's blurry and they're thinking, I just need glasses. Maybe even I just need cataract surgery or something like that. And then you have to tell them that they need a different kind of treatment, that maybe not what they thought, and that they have problems from diabetes, or maybe that they have diabetes. It's a big responsibility to be that person for them. And on a broader scale, I think that's true of many people who come into the emergency room here who have new eye emergencies or decreased vision, that they trauma maybe, or something hit them in the eye, or all kinds of things that could damage your vision, hopefully transiently. But to be the person who gets to help them through that is like really one of the biggest things that's rewarding about what I'm doing for me.
I'm glad that you mentioned that some of the treatment is like that noticing it early makes the treatment or like the condition preventable. I want to talk about retinopathy specifically. Usually, from what I've heard in the community, if you go to the eye doctor routinely every year, if they do see some retinopathy, what kind of treatments are available? For me personally, when someone's seen in my eye,
Mhm.
my doctor was like, "We're just going to keep an eye on it. We're just going to keep an eye on it." Anything you
Yeah.
can
So
actually do other
independent
than
of
just
blood sugar
improve
control,
blood flow?
other metabolic markers tend to be consistent exercise, good sleep. Basically, it all kind of comes back to the damage to those tiny blood vessels. Things that tend to increase blood flow or improve circulation, like exercise, and things that tend to decrease stress, inflammation, and your sugar, which, are related to stress overall, like anxiety stress or lack of sleep, which increases cortisol, which is the stress hormone in your body, which can affect your blood sugar and your blood vessels, as well as managing any other conditions that you have, may or may not have, in terms of high cholesterol and high blood pressure and things like that. Those things, if you catch them early, the best thing to do is modify those risk factors without having to do anything to the eye. And the reason is that, kind of going back to the how it works, how damage to the eye from diabetes happens, there are a couple other things that you get a little quicker when you have diabetes, like cataracts, which aren't necessarily related to the altered or compromised blood flow. But in terms of retinopathy and diabetic macular edema, really the little blood vessels in the retina get damaged from the high sugar. And that can cause two things. One, it can cause the blood vessels to start to lack integrity and they start leaking, which is where you get inflammation and what we call edema, which basically just looks like little dots of liquid that shouldn't be there in the retina, because typically the blood vessels are really tightly screwed on essentially, and nothing leaks out unless we want it to, which would be like, vitamins, oxygen, things like that. But when they start to get damaged, inflammation, liquid leaks out and that causes inflammation that can blur your vision. And if you have enough damage to the blood vessels that after the point that's damaged pretty bad, you start to get lack of blood flow, or what we call ischemia. That's where you start to get things like retinopathy. And earliest manifestations of that are bleeding in the retina, protein aggregates in the retina, which we call exudates. And later manifestations of that would be things like bleeding into the eye, called vitreous hemorrhage. And basically, your eye tries to grow new blood vessels to replace the ones that are damaged, which you would think would be a good thing, but most of those blood vessels are not normal and they lack integrity, like we were saying with the other ones. So they can pull on stuff and they can bleed into the eye. And that's really where you get the differentiation between edema and retinopathy. Diabetic eye disease is kind of the umbrella term. And you have those two things as the big entities within that. And then there's a bunch of little stuff like cataract and things like that may be related to it. Yeah. Yeah, exactly.
AMD, etc. Yeah, gotcha.
It's interesting to me hearing you describe, like, whether it's liquid leaking or blurry vision or blood in the eye or, extra blood vessels or whatever the case may be. Like, and those are things that you may notice, like, might be the first kind of hints or clues that you need to go see the eye doctor, especially if you don't even know you have diabetes at the time. But earlier, you were talking about, even if your sugars are in control, like, the recommendation is to go get the screening once a year. And I think I can kind of speak for most of us. Like, I'm sure we've all gotten the eye dilation, and we looked at and had our doctor look at our eyes and those types of things. If not, definitely go do that. But it also seems like a thing where, if you're getting good A1C numbers and your doctor or your endo are
Yeah.
happy with your time in range, it's something that often gets pushed to the back burner. But what I'm hearing you say is that if you're good about the screenings, especially if you're already living with a chronic illness and you're diligent with the screenings, you can catch these problems prior to running into the issues of, blurred vision or seeing the liquid in the retinas, or these problems that become more acute
Yeah,
if you're just
exactly.
going
And I
through your
think
regular
that,
screen.
really the question is, even if we do catch it, to your point, Eric, if we do catch these things in the early stages, the question really is, do we need to treat it? And for a long time, they thought that the answer was yes. And more recently, the recommendations are a bit more conservative because we have such good treatments now that often we can bring things back from pretty advanced disease and save a lot of vision in patients. But the question really is it visually significant? Is it affecting your vision enough that we feel like it's necessary to treat? And is the risk of not treating it posing some sort of permanent vision loss? Macular edema, specifically liquid in the macula, which is the center of the retina, which is responsible for most of your detailed vision. If the vision is worse than 20/25 on our eye chart, and there's swelling or macular edema around the center of the macula, which is an even smaller area called the fovea, then we tend to treat that with an injection into the eye of a medication that gets rid of the little distress signals that those blood vessels are making, which causes the leakiness and which causes bleeding. And if the vision is at a certain threshold, and then in the outside of the macula, outside of diabetic macular edema, when we're looking at retinopathy, the question is it going to pose some sort of danger to your vision acutely, or is it going to cause some sort of permanent irreversible vision loss, which would be something like a retinal detachment from related to diabetes? And the way that we treat that can be either with an injection or with laser to the retina. But we don't tend to do that if there's just a couple little dots of blood or just a couple little proteins or exudates. But if we start to see these big new blood vessels growing, we know the risk is now starting to kind of outweigh the benefit of watching it. And that's when we.
And you had mentioned this already, but it kind of like flows into one of our next questions, which is like the progression of diabetic eye disease, diabetic retinopathy. Sounds like detached retina was what you had mentioned on one of them. Like blindness, is that sort of the end game? Like what is that progression due to the
A feared
retinopathy look
complication
like?
of macular edema is scarring. The liquid we can get rid of fairly effectively as long as it's combined with kind of controlling those other risk factors that we talked about. But if it sits long enough, that liquid in the retina can cause destruction of the normal function of the retina, which we would call an exudate or scarring if it gets right under the center of the fovea, then your vision often is very difficult to get good. That even if we treat the fluid, even if the fluid goes away, because the scarring takes a long time to go away if it will. Sometimes it doesn't. And so if we see little drops of macular edema underneath the fovea, right underneath the very center of your detailed part of your vision, we tend to treat those even if the vision is not super effective, because the risk is that it could cause a scar that we can't fix. So injections are really the thing that treats macular edema. Previously, we used to do laser in the macula, which is not something we do super routinely now. It still is an effective treatment, but often it can cause what's called a scotoma or a blind spot in the center. Maybe not right in the middle of your vision, but it's something that people tend to notice because that's where they get most of their detailed vision. It's effective, but we don't do it that often anymore because injections are so effective. For retinopathy, if there's a few little blood spots out there, if there's a few little exudates out there, they're almost definitely not going to be affecting your vision. And the treatment for those abnormal blood vessels that we were talking about that can cause bleeding or things like retinal detachments or even more rare forms of coma, because those abnormal blood vessels can grow in the front of the eye, not just the retina, and block the ability of the eye to drain liquid. The treatment for that is injection or laser to the retina. And the laser, if you do it early enough, can often prevent a tractional retinal detachment, which is the kind of retinal diabetes, and very effectively prevent bleeding. The key is really kind of picking when the benefit outweighs the risk, because every spot of laser you put, the reason we don't put it in the macula, right, is because it can cause a blind spot. Every spot of laser you put, really, it acts as two things. It kills the retina that's there so that it stops making this distress signal that's calling for the new blood vessels to be made. And it acts like kind of a little spot weld, because the retina is a layer that's sitting on the back of the eye. You can weld it in place, then it's less likely to get yanked up, which is a retinal. But, potentially that can affect your peripheral vision because we're putting little spots of laser there. So we don't make them touch each other so that it's less likely that you'll notice, but we don't want to do that if we don't have to. And that's something we have to kind of weigh risk and benefit.
It's so interesting to hear you describe it kind of from beginning to like treatment. I think, we've talked about it a little bit on the podcast, but a couple of years ago, I've had type 1 diabetes for 22 years now. Hey,
Happy
me,
anniversary.
that was yesterday. But a couple of years ago, yeah, thank you. a couple of years ago, I came home from a long trip. I've been like in Europe and Africa, like all these places. I came home and I was really frustrated, and suddenly out of nowhere, I was in a bad
Yeah.
mood, but out of nowhere, I started seeing like dots in my eyes. Just it was completely out of nowhere. And I truly started freaking out. It was literally December 29th. So everything is now closed. I called my eye doctor, who was opening up the next day, for a couple hours in the morning. And I'd been seeing the same eye doctor since I was diagnosed when I was 8 years old. So I know this guy, whatever. I go to the appointment. He's looked at my eye. He's like, well, we've known you had diabetic retinopathy for the last like 5 to 7 years. We've been keeping an eye on it. It looks like it's progressed, and now it might be something else. So I'm going to write you a referral to a friend of mine who's a retina specialist. And I was just like, okay, when am I going to be able to see this friend? It's literally New Year's Eve. I am like freaking out. I remember going to get an eye patch from Walgreens because having those dots in your eyes was making me have a headache, and just like it was not fun. And I quite literally was telling myself, this is the beginning of me going blind. Like I would sit outside and like with one eye cover and like look at the sky and be like, take mental pictures, because you're never gonna see the sky again, girl. Like this is it. And when I finally got in to see the specialist, I remember being really freaked out because everyone in the waiting room was like 60 years old or older. And I was like, what the is happening to me? Like I'm not amongst my people. And finally getting into the specialist, they did all these like drops, and they did like a weird IV that they were like, we have to put dye in your eye. And I was like, what is this? What is happening? Did the dye in my eye, and then the doctor came in, Dr. Koziliak, he's great, I love him. And he was like, do you understand what is happening? And I was like, no, break it down, because I am panicking. And he said, basically, if your eye was a house, the basement is flooded. The basement is completely flooded. And I was like, so what do we do? He's like, well, we got to drain the water out of there. And I was like, okay, what happens after we drain the water? Do we throw the basement away? Do I get new floorboards? Like, what is the step-by-step here? Don't give me an analogy, bro. Like, I need to understand. He said, first, we're going to drain the water out. We're going to completely drain the water out, and then we're going to bring you back in 2 weeks so we can see if there's still more water. And I was like, okay, what does drain the water out mean? He goes, we're going to use a laser today. And I was like, a laser in my eye? Yes. I was like, okay, it's going to hurt. He's like, no, we're just going to do some drops to numb your eye, and we're going to do that. And I was like, okay. So we did it. It didn't hurt. I'll be really honest. I was expecting a lot of pain. I just sat there. They flashed a light in my eyeball. And then I went home. I had to Uber home because I couldn't drive. I Ubered home. I came back in 2 weeks. He looked at my eye again. They did all the same stuff again. The dye, everything. It takes forever. And he was like, okay, basement is drained. There's no more water in there. We need to rebuild the floorboards now. And I was like, well, what does that mean? What does that treatment look like? And he's like, well, we're going to do a shot. We're going to do a shot today. You shouldn't need more shots, but I want you to keep coming back every 3 weeks for the next 2 months so we can make sure. And I was like, okay, cool. I'll do that. Came back. And we did the shot that day. Didn't hurt either. I was like, why doesn't this hurt? You were putting needles in my eye. Like, came back for 6 weeks. Everything looked great. He was like, you still look good. I think we're going to do treatment as needed. That's what I think we need to do with you. You're pretty young. You're only 29. Let's see you every 3 months now for eternity. And I was just like, for eternity? And he was like, yeah, because I never know when you're going to need treatment again. So that's where I'm at now. I think last September, I was with Rob in Denver, and I literally was like walking down the hall, and he came up to me and was like, what's wrong with you? And I was like, I have a floater in my eye, because it was the first time I'd gotten one in 2 years. So my question then becomes, is that a normal diagnosis story? Is that just how it happened? Because for me, it felt very out of nowhere, and I truly thought I was going to go blind, and this is all my fault.
Yeah, I
and
think,
now I'm totally
it kind of
fine.
depends
So
on how much or how involved your discussions with your ophthalmologist were over the years. When you were saying you are aware that you had some degree of diabetic retinopathy, we basically categorize macular edema into kind of two categories. There is, you can basically think about it as something that's threatening your vision right in the middle, what we call subfoveal at perifoveal, or extrafoveal, which is less scary for us, because even if it scars, it's not going to affect your central vision. And then you can separate it into kind of clinically significant, where it's affecting your visual acuity on the chart, or not visually significant, so not affecting your visual acuity. For retinopathy, we separate it into two categories broadly. Proliferative, meaning that there's new blood vessels, and you can diagnose that based on what the type of test that you had, which is called a fluorescein angiogram, where they put a dye. And basically, The pictures are really, really cool. Actually, if anyone ever wants to look them up, they use it for all kinds of different things outside of diabetes. But fluorescein angiography basically highlights any blood vessels that are leaky, like we were talking about. And we'll also highlight any of those abnormal tufts of new blood vessels that are growing. And that's one way you can diagnose it. If it's hard to see into the eye, that's one that we usually go with. And if there's bleeding, by definition, you have a type of proliferative retinopathy, because we know even if it's hard to see, somewhere in the eye, there's an abnormal blood vessel that's causing it, assuming that there's not a different cause of bleeding in your eye, like trauma or something. And then on the other side of that, in the retinopathy, there's proliferative and non-proliferative. And then non-proliferative is based on scale mild, moderate, severe, which is based on some of the classic diabetes trials. Newer, I guess, classification schemes have been proposed, because those old school trials, which were, props to the OG ophthalmologists, because they were doing all this based on exam only, like not even good photos. A lot of times they were literally counting the number of little bleeds that you have in your retina. They say, okay, this means mild, this means moderate, this means severe. And then there are certain characteristics of that you can separate into high risk or low risk. And that's for progression to having the bleeding. So if you knew that maybe you had severe non-proliferative retinopathy with high risk features, that would be less surprising than if you had, say mild and you were getting annual eye exams and your A1C was 6.5. It'd be very surprising if you progressed from mild non-proliferative all the way to bleeding in your eye over the course of a year with good. That would be surprising. But if you knew that you had a higher level of retinopathy, maybe it would be less surprising.
You brought up something really interesting there, and you referenced it as
Yeah.
like the classics, the
Nice.
deep cuts, the OGs of understanding the eye health and how, and you were talking about like manually counting, like on examination, not even having good film. Like, how has the examination process and the data that's collected, how has that progressed recently? It's even, let's go back the last 20 years or so, because this kind of fills into that theme that we've been talking about on the podcast, that it really is still early for a lot of diabetes
Yeah.
treatments, that, it's been 100 years since insulin. And then all of the other things
Yeah.
since then, we've sort of been, learning about along the way. And so I'd love to know, like, for somebody who was getting an eye exam 20 years ago, what they were looking
Absolutely.
for,
So,
how they were looking for
we
it
have good
compared to what you're
example
seeing
photos of
today.
a lot of these things. Diabetic macular edema used to be diagnosed based on essentially those protein aggregates, or the little on a photo. I could show you photos on my phone if you want. Little yellow dots in the retina. And that's a sign that there was fluid there at some point. So if your vision's blurry and there's signs that you've had fluid before, the conclusion was drawn that you have fluid now, and that's why your vision's blurry. So they would treat it that way. And for retinopathy, they would look at the extramacular area and see if there was any evidence of new blood vessels growing, any evidence of new or old heme in the eye or blood in the eye, which tends to settle to the bottom if it's old and look kind of like whitish or khaki instead of bright red like new blood, and go from there based on what they thought that you need to treat. Of course, if you have any sort of manifestations of advanced disease, like what we call neovascular glaucoma secondary to diabetes or retinal, that would be a sign that you have advanced disease. Nowadays, we have the more advanced imaging things, like the fluorescein angiography will give you very easy to see diagram or readout. I guess you have to interpret it yourself. No one does that for you, but the photos are much easier to see, and they're very easy to see compared to a normal exam if you have blood in the way, because they are very bright and kind of like light up, as opposed to you having to try to peek through the blood when you do your exam, which is difficult. And for diabetic macular edema, we do what's called an OCT scan now, which is essentially a cut through the layers of the retina, and it'll show you a little black dot, which represents fluid or a leaky blood vessel, instead of doing just looking they used to. But those original studies were really impressive. I think on the note of original studies, you might find, if you look at the incidence of someone who is diabetic type 1 or type 2, the statistics are different. But basically, if you look at the incidence of some degree of macular edema or some degree of diabetic retinopathy at 20 years, the odds that you have it are pretty high. Somewhere between a third and a quarter of people are going to have some degree of it. What I'll say is that I think that, those are based on the older studies, and that's before we had the treatments that we have now for diabetes in general. And, nowadays we're catching a lot more macular edema, because before it was based on looking at if you've had some sort of old swelling that never went away. And now we're able to catch tiny, tiny, tiny things that are probably not clinically significant. And anytime we have a new imaging modality in medicine, we have to make a decision on if we're going to care about it or not. And in terms of macular edema and retinopathy, it really kind of depends on what's affecting you and if we think it's going to affect your vision in the future. But we're catching a lot more stuff now, for sure.
And that's interesting that you bring that up because, it's like we're having more awareness, having better imaging, having better screening leads to more diagnoses of, DME. So it kind of like skews the data in that way. Like because we have the access to it, because we have the new testing, more cases are being reported. But that's just stopping like the rapid development or the late stage cases, or maybe even some of like, proven
I
leaders because we're catching it earlier.
That's
A
actually, I think,
non-scientist, an
more,
idiot,
that's
like
a good
interpreting the data.
interpretation that I think a lot of scientists who get excited about the imaging and the pre-pictures, which I do also, don't really take into account, is that probably there's some degree of inflation, if you will, in terms of diagnoses, because we're catching things so much more readily and it's so much easier to screen people. Even at home now, there are, we have imaging centers people can just go to just for a photo of the retina. You can do it undilated and you can see really well, pretty far out to the edges of the retina to catch things that people who don't have time to come into a full visit for a dilated exam and, be out of commission in some cases for, 4 hours, 6 hours, the rest of the day, depending on how long your eyes stay dilated and what you do for work. Even cell phone cameras, there are attachments that they're developing now and in beta testing to see if people can take their own retina photos on their cell phone with a special attachment to see about screening people at home for these. We're just going to catch a lot more.
So with that as well as like as we're catching it, as we're diagnosing it at different times, is there a specific time frame that we need to be aware of it, or as a patient and a listener with diabetes, is DME like can it pop up at any time? Like we've talked about, it's like it's not always
Yeah.
related to your HbA1c or your time in range or your control. Sometimes, like you had a big nod when Eritrea was talking about how long she's lived with diabetes, and like, so is this something that can happen at any time? Is this something we need to have more awareness of as
I
we
think
live longer
definitely
with
we're going to
diabetes? As
see
this could pop
probably
up?
more subclinical cases as we live longer. I'm hoping, and I understand that I'm coming from a place of being very fortunate in terms of having had access to like the loop system and everything relatively early on with my, mentors at Stanford getting me connected with that, which has been, and for everyone who doesn't know, the loop system is a kind of jailbroke artificial pancreas system that has been saving my life for the last 9 years, which has been incredible. Recently FDA approved. Yeah. Yeah, exactly.
Recently
I'm trying
FDA
to get on that train
approved
as soon
as
as they
well,
have it
which
for
is
iPhone.
exciting.
But it's been, I mean, that technology I think has the potential to really change the trajectory of people's diabetic complications, because the degree of effort you have to put in to maintain a relatively low A1C is so much lower. And even, once you stop inputting variables, like if you're asleep for 8 hours and your sugar is 120 overnight, that's significantly going to decrease your risk of having any sort of complication by you doing almost nothing extra. And then, not to mention putting in some work during the daytime as well. But those data, I think, are probably going to continue to be rising, potentially with some aspect of inflation from the better imaging that we have. But as we live longer, I think yes. And the risk factors tend to correlate well with control for diabetic macular edema or retinopathy, with the caveat that if you have some sort of other, we would call it a vasculopathy or a coagulopathy, where you're more likely to damage your blood vessels from some other reason, like cholesterol or blood pressure or other diseases or other conditions, genetic conditions in some cases, you're more likely to have those things develop even with a better controlled A1C. And the one other condition that we see, not really a medical, I guess it's a medical condition, not a disease by any means, is pregnancy tends to accelerate these things. And pregnancy tends to third space fluid into different places, which, basically just means that in different places, fluid goes where it doesn't usually go. For example, swollen ankles, fluid stays down there a lot of times in pregnant women. And a lot of times we see exacerbation of macular edema in pregnant patients. So that tends to that's an area that we keep a very close eye on, especially in our type 1s. I think that to some extent, it's on the doctor to help reemphasize that this is not a fault thing. This is a condition that we're going to manage together. And I really feel strongly that people who try to put the fear of God in their patients by, essentially saying you are really going to hurt yourself if you don't try harder and things like that, which I've had, expressed to me before. I think that's really damaging to the relationship between physician and patient. I think that you have to be honest with them, because sometimes on the flip end of the spectrum, there's people who have very serious disease who don't necessarily take it that seriously. And there are people who have very early disease who don't think that it could get serious. And even from the beginning, I think it's important to be honest with them about what could happen in terms of complications. And the incidence is high. One out of 3 people with type 1 diabetes, and a little bit lower, but similar statistics for people who are insulin dependent type 2s, have some degree of macular edema. And that's not something to be ashamed of. It's kind of similar to how, when I talk to patients about their cataracts, this is a good point that Rob brought up, that it is almost a badge of honor to have a cataract, because you've lived long enough that your normal lens is now exhausting itself. And I can help you with that. It's one of my favorite things to do. And one of the most gratifying surgeries that I've ever done, where patients come in with only being able to see potentially hand waving or, light only, can't read anything. And the next day they could be 20/20, they could be 20/30, and they're extremely happy. And that's one of the most
Wow.
gratifying surgeries in the world for me. But when I talk to them about cataracts, a lot of people who are between the ages of 40, 50, and sometimes in diabetics, particularly type 1 diabetics, those cataracts develop quicker. And I tell them they have some level of cataract, which may or may not matter in terms of their vision and probably doesn't need surgery. And they're all very surprised. And I'm like, it's actually a good thing, because it means that you've lived long enough to develop this. And that's hard. In a lot of places in the world, it's very hard to do, especially with diabetes. I think I ask patients a lot, what is your understanding of what's going on? If I've seen them before, and like I said, one of the coolest things about Bascom Palmer, where I am, is that we have a continuity clinic since day one when we get here. So some of these patients I've been seeing every, month for the last 4 years, and I've been doing their injections or lasers as needed that whole time. And we have a very good relationship, and they are on board with what's going on. They understand the treatments. They understand when they need it and when they don't. Some patients come in and they know exactly what's going on every single time. I have new floaters. My vision's gotten blurry again. That is something that if I know them, it's easy for me to judge. If it's the first time I'm seeing them in the ER, for example, sometimes patients will come in with acutely decreased vision or new bleeding or something like that. And I ask them, what do you think is going on? And then we kind of go from there, because they might, like I said, they might not even know that they have diabetes. And we have to start from that level. Do you know what diabetes is? Sometimes it's, I know I've had diabetes, but I'm not on medication. My doctor said it wasn't that serious. And then you have to say, okay, well, I think that we need to, when was the last time you saw your doctor? When was the last time you had blood work? And kind of go from there. And if they need treatment, then that conversation becomes a little bit more granular and condensed, because you have to get to the point where you say, okay, these are the risk benefits and alternatives to doing what I think we should do, which may be injections or laser. But overall, a lot of the patients that we see have a pretty poor understanding of diabetes at large. And definitely diabetic eye disease is not something that's super commonly talked about. And I'm glad that you're, opening up that can of worms to the audience, because I think it's super important. And with the technology and treatments that we have today for screening, and with the screening technology and the treatments that we have available to us, we can prevent a lot of advanced disease, and we can bring back a lot of vision in eyes that have had some damage from diabetes. But people have to know that.
It's really interesting to me, like you talked about patients and seeing patients that they didn't know they had diabetes. And we see the stats, and I think in particular at Diabetics Doing Things, we've been, because of our work with North Texas Food Bank, really examining sort of the fringes of diabetes awareness, where especially in senior populations who, like we've talked about, you live long and your gear starts to wear out a little bit, for lack of a better word, or lack of a better term. Diabetes is more prevalent in those populations. And yet, like, I saw some statistic, it's like up to 50% of people living with prediabetes don't even know that they have it. And to your point, maybe they talked to their doctor 10 years ago about, hey, you're living with diabetes, but like there's no need for action now. And now 10 years from now, it's like, okay, well, there maybe is for oral medication, or maybe they need insulin dependence, or whatever the case may be. But, for you, I imagine that's like a tough emotional burden to carry, where somebody came in for an eye issue and you're telling them, oh, well, not only do you have this eye issue, but it's as a result that is going untreated.
For me as a diabetic, I tend to try to take that as a positive, that I get to do it as someone who does understand what they're going through in a lot of ways. And it's hard. It is hard. I think it's the hardest thing is when you get a referral for someone to come see you. Someone may have seen them before and didn't fully explain what was going on. For example, if there's a comprehensive doctor, or maybe even the primary care doctor, or possibly someone who is within the same network as you and they just said, you need a retina specialist, I'm going to send you to Bascom Palmer to see Dr. Tijerina, but didn't really explain what was going on. Sometimes it's hard to explain to the patients that maybe they don't have reversible vision loss. Maybe they're, maybe it's scarier to do surgery than the benefit that we can offer them. Those are very advanced cases. And I think that if you catch things early, that tends to not happen. But there are cases like that. And that's really sad. It's really hard emotionally to be the person who has to say that to them, especially if you feel like they kind of got kicked down the line a little bit towards you. But as someone who lives with that worry that I'm someday potentially going to develop, diabetic retinopathy or macular edema or something that will limit me, not necessarily, I guess, because like we were saying earlier, it doesn't always affect your ability to do things, which is part of the beauty of screening things early. But to live with the, potential, the potential for complications in the future, I think that gives me at least a better window to see where they're coming from in terms of if they're anxious or if they're scared or if they're, versed and they're not wanting to be around to even like get that talk. Sometimes people are just scared of it and they don't want it, which I get, which I do.
Well, we kind of joke about it. Like the complications is a scary thing to talk about but we're coming around to it. I think on the podcast, I think it's something that we have uncovered in conversations, even within the community of the
Yeah.
stigma of living with complications and how, some of that rhetoric that we have been all sort of collectively unlearning about, like, you can do anything that you want and diabetes doesn't have to stop you is like, that's true. But there's also like some real obstacles and real challenges that you're going to have to live with and face. And that doesn't make you less of a person or doesn't make your accomplishments less, impressive. It's not really even a reflection of you at all, as much as it is your physiology and maybe even genetic predisposition to different things. But what I've learned today, at least, and I think our listeners can take away from this is listen to your doctor and go to get your screenings. That's the best way to get ahead of it and minimize the longer term damage. Like, you don't want to wake up one day with a floater or, with a spot that you can't see and say, I really wish I could, or I really wish I would have listened to my doctor when they told me to
Yeah.
make my appointment with my ophthalmologist, or go and get the screening or the imaging done so that I have that awareness of where I am and where my eyes are and maybe even what my genetic predisposition to, things like diabetic macular edema is without knowing otherwise.
And also past that, if you do wake up
Exactly.
with a floater in your eye, call your doctor immediately. Do not wait. It's not going to go away. Like, I think a lot of times, and I don't know if it's just my brain or maybe just being scared, or sometimes I just think it's
Yeah.
immigrant culture, but a lot of times we're just like hoping it'll go away. And you're just like, if I just ignore it, it'll stop. But with stuff with your eyes, I've learned specifically, like, if you see a floater, go immediately. If they tell you they can't see you for 2 weeks, let them know that it's an emergency. Because I'm telling you, they'll get you in faster. That's been my personal experience, honestly. With that floater I saw in September, I called and was like, no, I can't wait 3 weeks. It needs to be this
We do.
week. And they were like, they got me an emergency appointment. They have slots for that for the doctors. So I think it's so important to also just, if it does happen to you, it does not have to be the end of your vision either
Yeah, no,
way. So
100%. A plug
sooner
for
you can get in,
Bascom is
don't
anyone
be
is
scared.
around in the
So
Florida area or can get to, the ER here in Miami faster than they can get to wherever their doctor is can see them. We're open 24/7, 365 days a year. There's 4 other emergency rooms in the country for eyes, but they're not common. But a lot of offices do have emergency appointments and ophthalmologists are well versed in what the potential emergencies are that could be going on. They're going to squeeze you in if you tell them that you're having floaters and they're worried that you're having a need for it. That's something that is going to be prioritized for sure in the vast majority of cases. And also,
something that you also mentioned earlier, and as I know we're wrapping the episode, but it was like that relationship with your ophthalmologist and like cultivating a good one. And something I learned was that my doctor from the beginning, I think I just got really, really lucky, but he was like, what is your vision goal? Which, who asks that, you know? But I think it's such an important question for all of us to answer for ourselves, especially if you're having some kind of floater or diabetic eye problem, to ask your doctor, whatever your goal is, how do I achieve that? Because for me, it was, I want to be able to see when I'm 70. Like, that is my eye goal. I still want to be able to see whatever grandkids I get to have, dogs, whatever, I want to see them fools. How do we get there? So I think it's also important for you to talk to your doctor
that's
about what that goal
huge.
is
And
and if
I
it's
think that that's
reachable so that
something
you can
that
get.
we don't always emphasize enough or didn't take the time to discuss with our patients enough. not just about diabetes, but for example, cataract surgery, things like that. Not everyone cares about their distance vision being 20/20. Some people spend all day reading the crossword puzzle, and that's awesome. But I want to help you do that. I want to help you do what's going to make you happy. And if someone was just, diagnosed with diabetes and started insulin at 80 years old, their glucose, to be frank, probably doesn't have to be as well controlled as someone who was diagnosed at 8 years old, because they are not going to have to worry about it for that long. Like in terms of risk, cumulative risk is going to be lower the years that they have with diabetes than someone who was born at 8. It's that simple. And that's something that I think is kind of a relief to a lot of patients if you tell them that. And we know from the big clinical trials originally that if you try to control sugar too much, then hypos go up, which are also very dangerous, So that's something just a wake up call for us when we were originally figuring out diabetes control, and the larger trials were showing, oh, hey, it's actually not always a product of just having diabetes as an entity that you're going to have complications. It's linked very closely with your A1C and your blood sugar control. Those trials, the subsequent trials, the Accord trial specifically, showed that if you control the A1C too tight, people have adverse events like very severe hypoglycemia. And that's something that has to be balanced. That's the bottom line, is that you have to hit your quality of life as well as your diabetes control. The only way we can know that as doctors is if we take the time to talk to the patient about it.